Just who you are, the organization you're representing, and maybe how long you or like what you've been doing related to opioid settlement stuff.
Hi, so I'm Christine Khaikin. I'm a senior health policy attorney with the Legal Action Center. We are a uh, 50 plus year old policy and legal nonprofit located in New York City, and we also have a DC office. I have been working on opioid settlement issues for several years. I worked with a couple of partners in New York State to draft our initial legislation creating our opioid settlement fund and advisory board in New York State, although I don't take the blame for all the problems. Um, and have been advocating for appropriate spending and other things in New York since it was created in 2021.
Thank you, Christine. Mishka, do you want to introduce yourself?
Sure. Yeah. Hi, everybody. I'm Mishka Terplan. I'm a physician. I'm boarded in OBGYN and addiction medicine. And I've worked with Jonathan and Ashton on reporting on addiction since really kind of close to when it started. And I'm the medical director of a research institute based in Baltimore, Maryland. And I've been involved with opioid settlement stuff also kind of since the inception. We had a grant from the Arnold Foundation early on to map out appropriate pathways for spending. There's a handful of resources like that, and I'll just briefly say that they have not been utilized in practice very often.
Yeah, thank you, Mishka. And I think we'll just jump in, and when Tracie joins, we'll have her like introduce herself, unless she's here right now. All right, perfect timing, Tracie, as always. Yeah, Mishka, if you don't mind, do you want to put in the chat that Arnold won? I think
I'll
I put
look for it and I'll put it in the chat.
sure. Hey, Tracie, how you
Hey,
doing?
Tracy.
Oh, you're on mute. That's okay.
Greetings.
You've only missed their introductions, but you know Michigan, Christine. So if you want to just introduce yourself and the work you've been doing related to like drug use and addiction, just for a background.
Okay. I'm Tracie Gardner. I'm the executive director of the almost 3-year-old National Black Harm Reduction Network. And it was kicked off in 2018 as the narrative around the opioid overdose was changing and leaving out a lot of work done by great Black harm reductionists and other organizers. So we've been our own entity, a 501(c)(3) since October of last year. And I am the New York State Attorney General's appointee to the New York State Opioid Settlement Fund Advisory Board. But along with Christine, we have been monitoring the settlement board process nationally. And then Christine and another New York Legal Action Center, New York policy person, Sebastian Solomon, were architects working with the legislators who were pulling together the authorizing legislation for the New York settlement funds and for the settlement board. So I am really always happy to see Christine's face, and she is a genius on this stuff. So there. And then there's also Aaliyah, who is newer to Legal Action Center. I didn't get a chance to work with her, but so far, everything that I see and hear that she does, I would have definitely aggressively hired her then.
Thank you, Tracie. Wonderful introduction for everyone. And like I said to start the day, we have a really badass panel. So really, really wonderful to have everybody be able to contribute today. I'm going to start with just a setting the stage sort of question because y'all know New York way better than I ever will or should. So what is going on with opioid settlement money in New York?
It's a big question. Can I start and then
Please.
all right, I will start. And there's just not enough time to get to everything in this hour, Jonathan. But What is going on with opioid settlement funds? So, as I said, we have legislation in New York that created a lockbox fund for all the dollars coming in, or the vast, vast majority of the dollars coming in from the settlements. Um, and then we also have an advisory board that makes recommendations for how settlement funds should be used. It's really important to understand, and this is true in like every state, but like every state has like a different formula of how the money is distributed and divided. And in New York, we have most of the money going either directly to counties and municipalities and localities, or through our state addiction agency to those counties and localities. The Settlement Fund Advisory Board and the state spending is about 35, something like 38% of the money. And we have an advisory body only. So Tracie sits on that advisory body, as she says, and they make recommendations for how spending can go for that 38%, but they don't direct actual funds. Our executive, the governor, can reject those recommendations. And so a lot of the concerns in New York right now are around transparency on what has been funded, both at the state level and the county level. There is a tracker that exists on our state addiction agency's website that is frankly changes sometimes, really hard to navigate, doesn't appear to include everything. At the county level, counties just began reporting what is happening in each county. That was required by statute that was passed last year. And so those reports came in November. Jonathan put our website in the chat. Legal Action Center just developed a website with advocacy tools and whatever, and we have a tracker on there of what counties are spending their money on, according to those reports, although a lot of them are incomplete or just like provide almost no detail to actually understand what they're spending on. So these are like kind of the main issues happening. The other thing is an advocacy organization in New York just put out a really awesome report, which I can put in the chat. They're called Truth Farm, and their report looks at state spending. And what they found is like, I think it's like over 70% of state spending has gone to organizations with budgets like over $10 million, and some way more than $10 million, like $50 million, like hospitals. So I'll stop there. I know Tracie's going to have a lot to say also.
Well, Tracie, I'll tap you in. A word that Christine mentioned is transparency. And so, what do we mean when we're talking about transparency when it comes to opioid settlement money? And how would you like to see it be more transparent? And then, relatedly, like how can journalists help in that cause?
So transparency, it's a tricky word, right? Because and I spoke about this with Bloomberg partners, because there's a lot of rate initiatives like this one looking at settlement dollars, or just kind of the implementation, right? A lot of what I initially learned about the challenges of tracking the settlement dollars and their use, I learned from Christine Minhee, who basically, and please put her website into the chat as well, but this idea that transparency could happen with settlements agreed upon by lawyers. I love lawyers, but I'm not one. I like to boss them around, but I'm not one. And I had never had an interest in being so. And so transparency and legal settlements seem to be incongruous, like totally opposite. And then you add the layer of government, which has never really, I've had it described as opaque. The processes of government have been opaque. And that's especially true when transparency means that the public should be able to look at the information and understand it and then use it. And so, in that way, the opioid settlement process, in and of itself, is not transparent. And it's difficult for it to be, but I think we are all making valiant attempts for it to be. As you know, Jonathan, a lot of my work around drug policy comes from my work 30 plus years ago in HIV advocacy. And transparency on funds were an issue then. And we had a couple of mechanisms to be able to not just ensure transparency and accountability, but community engagement that informed where the money was going. And during HIV, that was a built-in mandate on some of the federal dollars. And I really wish that the, that the HIV funding framework were a reference point for the folks who negotiated the settlements so that they could see that community involvement cannot be ancillary. It can't be after the fact. It needs to be right there up front. And I think we would have avoided a lot of the challenges that we see around the country in terms of the money getting to where it's needed most. And then finally, I would just say that it's world of addiction, treatment, substance use, much of what we understand the substance disorder treatment field was, as the opioid epidemic was emerging, was made as outcomes of the war on drugs or even further back. And so to believe that we can put new money and a new way of thinking about the people who are the users at the end users, if you will, to think that putting new money into those systems and those pathways were going to make sure that the money got to where it was going. No. Guess who got the money first? Law enforcement, because that's who used to get the money first always. So I'll shut up there.
No, that's such a great point, Tracie. And I can already tell that Mishka wants to like pull on that thread a little more. So Mishka, I'll tap you in at this point if you don't mind, like just expanding a bit on what Tracie was talking about, especially in terms of how this funding is really just in many ways in like re-entrenching some of those problematic ways that we spent money in the past around drug use and addiction.
Yeah, I mean, just to add that like some of the issues with transparency are made more difficult by the really heterogeneous way that funds are being distributed, so it's not just you don't just even knowing like is it at the county level, what parts are at the state level, who are the decision makers, and it gets very local kind of very fast, and as you go up from the county where it's sometimes more possible to like the nation where it's kind of it's impossible. But Tracie, I really, that point you're making about like kind of taking new money and just plugging and not like disrupting or rethinking systems, but just putting it into sort of existing systems that are can be seen as broken or could be seen as working exactly as they're designed, which is to keep people in particular places and in positions by virtue of the and. I mean, one of the big issues with addiction in general is that as a health condition, it's only, I mean, historically, 100 some years ago, it was part of healthcare. Then for most of the 20th century, it wasn't part of healthcare. And recently in particular with like sort of the whiteness of the opioid, the last opioid crisis has become part of healthcare again. But we have these systems of care that have been around for 100 some years. Residential programming, the whole IOP, OTPs to some extent, and those don't, which are opioid treatment programs where people get methadone. Those really exist outside of the formal healthcare system. And we've been, even without the opioid settlement funds, we've been trying to kind of like um, kind of like leverage these things that don't fit into the healthcare system. And when we think about disease, we think with anybody with almost any medical condition, you're treated outpatient or inpatient. And then there's sort of specialty. There can be some crisis stabilization. There can be skilled nursing facilities. And that's sort of it. But addiction, there's this massive landscape of different types of treatment programs and whatever. And we haven't really critically examined that. And opioid settlement funds, instead of rethinking the system of care and rethinking how most people how do you integration would mean you get access to preventive services regardless of the door you walk through in the healthcare system. We've been propping up stuff that sort of feels good, is a low effort lift. And in many ways, the settlement is sustaining a system of care that really doesn't, fit a contemporary, model of how we think about, addiction as a health condition, and much less its treatment, much less, recovery. So it's kind of like those worn paths, those pre-existing paths is where the money flows. And you're absolutely right. The deepest, the one is, to law enforcement. But in some ways, the distribution of funds sort of exposes, I guess I'll say, the logics of surveillance, both within policing and within healthcare.
Thank you, Mishka. Yes. That, I think that takes us nicely to, and Tracie and Christine in particular, you really know how the money's being spent in New York, even though it's very, very hard to figure out how it's spent in New York. And Mishka was just talking about some examples, or like broad examples of reinvesting in things that are broken or not working, and how we're not evolving using this money to evolve how we respond to these crises. Can you talk a little bit about how the money is being spent right now, and then also potentially, how you would like it to be spent or how it should be spent, which I think are the same actually in this case?
I would urge, because Christine, again, having been involved in the crafting the legislative language for the law that authorizes the existence of the settlement board, and how the funding is being managed, administered. There's a story to be told about, and I want to say this in a way that's just really educational. And it's great to have Dr. Mishka on the call, because there's also this weird silo that settlement dollars live in, and that is between the healthcare, or in New York, it's public health law, and mental hygiene law. Mental hygiene law, and I say this from the experience of 10 years ago being the Assistant Secretary for Mental Hygiene for the governor's office. And that's when I learned that in statute, there's a Department of Health and there's a Department of Mental Health. And under the Department of Mental Health, there are 3 offices: Office of Addiction Services and Support, Office of People with Developmental Disabilities, and Office of Mental Health. And those 3 agencies make up the mental hygiene landscape, not just in New York, but in most places, right? And those agencies and the people those agencies serve have been maligned, like I said, well before the war on drugs, right? Those are the agencies or the areas where we've had institutional responses, where we've seen institutional and other abuses of people who are vulnerable. And so that is something that really needs to be kept in mind, is that our state addiction agency became the sole administrator of 2.4 billion. Am I right? 2.4 billion over this period of time, several settlements, all of this that require infrastructure in an agency to be able to administer. So, and I don't, again, like Christine said, we could talk about this for days because the infrastructure in the addiction field is primarily for providers. It's primarily for certifications. It's primarily for regulatory stuff, not people, which is also why in the health department, the AIDS Institute, which exists in statute, was created by, because I've lived between two Cuomos. The first Cuomo set up a center of excellence to address the health epidemic that was happening then, and that was HIV and AIDS. So the primary drivers of HIV were happening among injection drug users and people having sex. And so that infrastructure was built 30 years ago in the health department under the AIDS Institute because providers who grew up with a regulatory framework that was informed by the war on drugs, the addiction treatment field in New York was carceral, and it was also very disruptive of families. So child welfare, jail and prison, and addiction treatment were lockstep. And I think that that is really what's hard to see about where we know the money should go versus being able to move these, long standing, almost, I don't want to say calcified, but they are, very much in place as existing pathways through which money would flow. So, one, those pathways and that infrastructure doesn't exist from my experience of looking under the hood of the state addiction agency. And on the AIDS Institute side, it exists within the health department, which of course is a giant entity that does have experience with these big dollars. But the health department isn't the champion here because we want to make sure the settlement dollars don't disappear into overhead of the health department. We want it specifically to go to the agency that has the experience in administering and working directly with organizations that are frontline and have the experience with dealing with these big chunks of money. So, there's legislative amendment language floating around that would split the responsibility of administering the funds for OASIS, because they should be in OASIS, but they should also be where the infrastructure for drug users and their community-led responses by and for drug users exists. And that's in the AIDS Institute in the Office of Drug User Health.
Yeah, no, Tracie, that's wonderful. And I love that background. I think that's really helpful. When you're talking about those resources, and we talked a little bit about it this morning, but can you articulate what are those resources that you would like to see it spent for that help drug users? What are the things that the money could go towards that again, we're not really seeing it go towards that, but man, this is a great opportunity to do that.
So for example, we all know harm reduction works. Harm reduction has been the most rigorously studied because it was always opposed. So the evidence base, if you will, on harm reduction strategies that are effective in reducing bloodborne disease, transmission of bloodborne disease, linking people to care, linking people to treatment, all of the stuff, there's a good investment of state dollars in harm reduction. But you can make the investment, you can authorize the money, but then how do you get it out the door? Right? Another thing, we all know that folks coming in and out of carceral settings are 140% more likely to die post-release. We need to understand the criminal legal system, the correction system, in order to make that available. And having MOUD in corrections is great, but not if you don't understand that correctional health is not anything like the health that it could be and should be that matches what we're doing outside. Um, Another place where funding is going and is really the development of workforce that's not just about, yes, we need to increase salaries and have people come into this field to do the work, but also really supporting the professionalization, if you will. So there's certifications that Oasis provides, they're providing fellowships, they're providing scholarships, and that's great. Some people may say, how does that help us? We are building a new addiction treatment system with this money, once in a lifetime money. And those are the kinds of things. And then finally, I would say we should be using funds for more capital projects and not capital projects that we built in the past that were really about institutionalizing, surveilling, and, kind of coercing people. But we should be building and investing in housing, not addiction housing, housing that stabilizes people whole health as they move along, whatever their relationship is with their substance. And Housing Works, for example, was the first organization to open up harm reduction housing where people were able to, they used, but they were housed. And then for many people, they were able to stabilize in their use or stop using enough to be able to go to another kind of supportive housing. Housing is medicine, and that's something we should be funding. It's durable, it will last beyond when the settlement money runs out.
Fantastic, Tracie. Thank you so much for explaining that. I really, really, really appreciate that. Christine, I know you've spent some time deep in some of these spending documents at the county level, and I suspect that some of the journalists that are either joining us today or will be watching this later will also be doing that. It is a interesting process, but what are some like kind of yellow or red flags, or how did you approach that? What did you see? What can a journalist like take out of that sort of journey?
It is a journey. I think that, you know, for what we did, and we have like a spreadsheet tracker, is we didn't really create an exact rubric, but we just started by kind of like skimming everything to see like what are they actually reporting, because um the actual like requirements on what is being reported and were pretty loose in my opinion, and then what counties took away from that in terms of like what they decided to report on was like all over the map. So in some ways it was just kind of getting a grounding, like time frames are totally different depending on the county. Some did like, some kind of fiscal year, some did like since the beginning, some did since the requirement was passed. It's really all over the map. And in terms of detail, you have some that said like, okay, we spent it on prevention, treatment, harm reduction, and recovery. And that's just like the categories that, are kind of in the law. Like you have to spend it on prevention, treatment, and there's no other detail, and that's several. And then we did find some that actually have made like kind of comprehensive trackers, which is great. That's transparency. We can like see what they are saying they spent it on, but then we have to like evaluate like is this a positive? And it's so interesting to see what counties will report on. They'll give you a lot of detail, be very open. We spent it on this. And I think in some ways they believe that they have done something good. And they're like, we spent all our money on canines and new police cruisers that are outfitted to transport canines. That's obviously like a criminalization approach. And they're very proud to announce this, which I found fascinating. Like, I think some of the counties that were being kind of like not so clear on it, uh, maybe feel like they didn't do the best job. But then I think a big trend that we saw in a lot of counties is like non-evidence-based prevention. So a lot of like marketing campaigns, a lot of school-based programs that are sort of like not even really related in any way to drug use or addiction. So like student leadership initiatives, things like that. We saw that in several places. And so we just really had an eye towards like, is it evidence based? The other thing that I think we is very hard to find is like the decision making process used. Like, are they actually using like RFPs? Are they evaluating these things in any real way? Are they just, are they kind of adding money to existing contracts? That was something else. We saw a lot of like paying this person's salary for this year that already works at like the county mental health agency or something like that. So it's really all over the map. I think when digging into it, for me, it was like, how much did they get? How much did they spend? What is this time frame that they're even reporting on? Because it wasn't consistent across the counties. So, and then I think what would be great and is for journalists to start digging into like how are these decisions being made and why is there any public input whatsoever. That's the kind of like local reporting that I think would is like really needed kind of all over.
Yeah, thank you, Christine. A word that you mentioned, and Tracie's mentioned, and Mishka's mentioned, it's come up a few times today, is evidence-based. And I know, Mishka, you worked on those national guidance documents with that Arnold Foundation report that you mentioned. Do you mind talking a little bit about like what do we mean when we're talking about evidence-based, and how can that kind of apply to something like opioid settlement funds?
Um, I mean, somewhere like not to begin by problematizing the term, but it can be a term that's sort of bandied about and misused. I'll say, both in terms of overstating what the evidence is, and by evidence I would mean, uh, data that are oftentimes come are published through a peer review process, though not exclusively, and ideally information that has been validated, i.e., sort of repeated. The observation, the association has been repeated across, different studies and different populations. Tracie mentioned earlier how, like, the evidence base for harm reduction. So that would mean looking at whether the availability of syringe services decreases the transmission of HIV or Hep C. That's been well established, across a multitude of science, or might also mean, sort of the relationship between this supervised consumption spaces or overdose prevention sites, and reduction in overdose. And then there's other parts too, like how syringe services actually reduce the amount of discarded syringes within a community. There's I think you're spot, like the idea that because it's been so contested, actually the evidence base is so strong. So that's what kind of like we mean by evidence based. Sometimes, though, I think it's more like, I think maybe sometimes evidence informed might be a little bit more approachable, because the base makes it kind of binary and people can be like, there's no evidence, there's only evidence. And it is true that there's, this, especially in the United States, we're like, markedly like diverse across a whole host of indices, population, and not everything has been studied in every single subgroup. And so somebody could say it's not, we don't really know how, whatever the provision of housing services in upstate New York, would impact, overdose rates in the community. It's possible that that specific thing has never been studied, but we have a body of evidence that, that we can rest upon to show how housing, and stability more generally, like actually improve like health and wellness. So for this Arnold project, this was like, I think it was published in 2020. And so that was a while ago. and it was broken into chapters, and different people took sort of charge of each of the chapters. And it was, calling it evidence based, I would call it evidence informed, because it wasn't a systematic, review process. It was resting upon, kind of the expert opinion and knowledge and relationships that the different chapter authors had. It didn't, grossly, it wasn't, it's set up to sort of interrogate people's pre-existing biases, honestly, in the construction of the chapters. But the concept, like, probably the biggest takeaway was that if you're going to spend money, the money should be spent on stuff for which there is, evidence that it, improves something around opioids, be it sort of prevention, treatment, or recovery. Um, and and as opposed to, and there's also stuff for which when we say there's no evidence, it can mean two different things. One, it can mean it's not been studied, but it can also mean we have studied it and there is no effect, or that we've studied it and there's a negative effect. And so, especially, like, I would say it's not just funding stuff for which there's evidence of benefit, it's not funding stuff for which there's evidence of harm.
Awesome. Thank you for explaining that. Really appreciate that. I want to drill down a little. I guess maybe this isn't even drilling down because it's a broad question about New York. But what are some differences between some of the resources and structures that are in place in some of the more rural parts of the state versus some of the more urban city sorts of the state? And how has the crisis like changed over this 26 years, and how has that been reflected in those places differently?
Well, so this gives me an opportunity to talk about data, right? And how different kinds of data and information, and how journalists um, can avail themselves of the data that in some cases is vast, but there's even something to be said when the data isn't as robust as it should be. There's a meaning behind that too, right? So, we're all seemingly celebrating the 35% decrease in mortality across the country. That, I think that's a New York stat in particular. The governor has touted it, the commissioner of Oasis has touted it. My issue has always been, and because I'm horrible at math, right? Like, I think I have dyscalculia, like that's a real affliction. So I freeze up when I see numbers. But 35% decrease in mortality hides, number one, the morbidity impact, which nobody's tracking that, what's happening to people who do survive their overdoses. And then it hides what's happening at the more community level, neighborhood level, even county and city level. So we all know, for example, that overdose and suicide are the leading drivers of Black maternal mortality. And it's unique. It's not unique to New York City. And I would gather that could be, these are the kinds of more localized impacts that are hidden by 35%. Or I've always been, in talking about my math problem, like, but the denominator is smaller, right? Of the people who we could have prevented overdoses in, we didn't prevent them. They're gone. And so that population is smaller. And so that's, stuff to, that's just lands very hard, that there are people that we could have kept alive who are no longer here. The other kinds of issues that are obscured by the easy to digest data and the easy to digest numbers are the other, in New York, 40% of the overdose deaths are happening not just in homes, but at home, like with people around who may not even recognize that the overdose is happening, who may or may not know how to reverse an overdose, who may or may not understand the intermix of drugs that could contribute to an overdose. The fact that we have a polysubstance use effect or impact on the morbidity, I'm sorry, the mortality is big. Again, this is data to go and into and ask the why, like investigate and interrogate the numbers that you're given, because there's always a story underneath them. So in New York, we have this database called Suitors, which is pulling together various data sets to give us a picture of what's going on. And everybody always thinks, oh, it's people without homes on the streets, chronic. It's folks at home. It's young men, young Black men in neighborhoods where violence interrupters are working and saying that they're losing more friends to overdose than gun violence. Like, if we're not in that sphere, we're not going to capture that opportunity for settlement dollars to make an impact. But I, in particular, because Mishka's on here, and if I were young enough, I'd want to have a baby so that he could be my OB. But what's going on with Black maternal mortality and the environment of danger that surrounds pregnant and postpartum people driving that rate is something I would love for him to speak about, because that's a story. And what needs to happen in order to cover something like that?
I'm not gonna answer that exactly, but what you're talking about also makes me think of like another storyline, and this is sort of within all of this, which is like, so settlement funds can go to things that actually the system could pay for. So medications for opioid use disorder should be paid for through like the traditional health insurance system, including Medicaid. I'm not sure how much this is really an issue in New York. It's some of an issue, and it's definitely, I think, a greater issue in other states. But we're looking at Medicaid cuts. Medicaid is the largest payer of prenatal care, or pays for the majority of births in the United States. And so you've got like, we talk about syndemics, like Hep C plus, opioids and as a syndemic, like connections of epidemics. And there's also sort of these social factors that are contributing to potential like syndemics in maternal death. You've got like, systemic and structural racism, plus like discrimination in the healthcare setting, plus, contributing to a decrease in access, to prenatal care, and contributing to really epidemic rates of maternal death. Just to put a number on it, Black women are between like 3 to 5 times more likely to die in childbirth in the year postpartum than white women are. And overall rates of maternal death in the United States are, and certainly in some small communities, are at or greater than that reported in markedly under-resourced settings such as rural parts of sub-Saharan Africa. So it's a blight on the system, a canary in the coal mine, like whatever you want to look at. And it's multifactorial, and opioids contribute to it. In the state of New York, I think opioid related deaths are one of the leading causes of maternal deaths, and those tend to happen actually not during pregnancy or the birthing hospitalization, but actually happen postpartum. And in many ways that reflects, which is the year following birth, and that reflects sort of the how care, we do still sort of provide prenatal care, but it, tends to stop in the postpartum period. And there's a discontinuity that happens, around birth and and into the postpartum period. And that sort of like loss of care is what, like, one of the things that relates to return to use, overdose, and overdose death. Another thing that contributes to that in this population is the child welfare system. There's a direct association between, people being reported to child welfare, having their child removed, and returning to use and overdose and suicide. side, because it's kind of hard to tease those out in data actually. And so, there's those are the sort of like the structural components. So I think just like one thing people can pay attention to is like, is the funding going to something that could be paid for through something else? And that would be a definition of waste.
Thank you, Mishka, for explaining that, and Tracie as well. And I think Christine, if you can add on like some other story ideas and things that you would love to see journalists dig their teeth into when it comes to opioid settlement money. I know you mentioned a couple things in terms of specifically like process stories. Who's at the table? How are those decisions being made? And all of you have worked with journalists that are covering this. So what are some things that you've seen that you've really liked and like could be replicated in either a local level or just in New York in general?
Um, so in New York, actually, the one thing, and I think this kind of relates with what I mentioned before in terms of like process, is the idea of how decisions are made from the standpoint of like who is getting the money and why. And a great piece, I don't know if he's on, is Adam, what's his last name? From Buffalo,
Smith
who
Perez,
did,
yeah,
thank you, thank
yeah,
you.
yeah.
Did a really great piece looking at the city of Buffalo's and funds that they were spending, and in particular towards agencies that have been site audited or real concern, but I think it highlights like the just uh, going deeper into the decision, something that has like not been dug into that much. I really like this concept though
Oh,
of like
can I
if
stop you,
it's
Christine? You broke up during the whole Buffalo part. So just like, it's okay. Just
oh
like explain what you were saying there again. Sorry.
sorry, I'm having internet issues. So I'm using my like hotspot thing, and that's apparently not working either. Um, Yeah, what I said was that he did a piece in the investigative post about the city of Buffalo spending settlement dollars and funding organizations that are in trouble, being audited, like not clearly providing the services that they are supposed to be providing, not doing what they're supposed to do, and just like the lack of follow up there. And I think that that really goes to this process question, and also this concept of like, which I really liked what Mishka said about, if there, it's such a clear, easy way to frame it. Like if there's other funds for this purpose, then that's waste if you're using opioid settlement dollars on that. And what that makes me think about is the total, like the real lack of funding for community-based, grassroots, mutual aid organizations on the front lines in neighborhoods run by directly impacted folks who struggle a lot to get traditional funding sources, right? Like they're not getting federal dollars, they're not otherwise getting state dollars. Foundations right now are just like not funding this work. It's just like a total absence for some reason. And that's where settlement dollars and other streams of funding that really don't have, a lot of strings, like that's where that could be going. And digging into like why not, I think would be really interesting. I like spent part of my day yesterday like reading like New York procurement laws and like trying to understand why there aren't exemptions for these things. Tracie knows that the state agency, our lead state agency, Oasis, is just constantly citing procurement laws sort of without citations or evidence of why they can't fund certain things. And I think like digging into what that really means is something that I think would be interesting, from a legal perspective, but also for journalists to like really dig into like why, you know, what does that mean for like the system, right? I think both at the county local level and the state level, I think that there's a lot of questions about that.
Would you feel comfortable giving an example of like when procurement laws are cited as a thing that they can't fund? And like what are the types of funds that they're denying or like not willing to fund? Tracie, you were going to jump in.
Yeah,
Yeah,
yeah, Tracie, go ahead. Yeah.
because this has been a big issue. One of
Yeah,
the
yeah.
things is really, never mind, you talk about transparency, understanding any state or county's budget process sometimes just require, I've been going to Albany for more than 30 years. And to say that I understand budget language or budget processes would be a bold-faced lie. But there's this concept of making money available, authorizing money, getting it out the door, having contracts registered that allows you to say a bunch of different things about to what extent is the money in the hands or where it is most acutely needed, right? And so, one of the things that the settlement board, the New York Settlement Board, has been talking about, asking about is can we figure out a way to have a larger organization that can navigate grants gateway, which is part of the whole New York State procurement process. And if it comes from, the executive, it has to be RFP because there are people on the board, there are organizations on the settlement board who get settlement funding. It's not a conflict of interest because they have to be subject to the RFP process. And so even though I've said it's foxes in the chicken coop, but there is a procurement process that makes that not so blatant. Like, however, this idea that organizations who are closer to the problem and able to do more aren't able or necessarily have the infrastructure to apply for state dollars. It's just right. So the counties have been really great to the extent that they understand that. And with their share, which is bountiful, they've been able to support organizations. But, it's still like the state money, the county money, if it's not getting to the folks, if you're sending it to a hospital system, you're going to have to wait a while. Like, I'm old enough to remember trickle down from the Reagan era. And we have an urgent health crisis, and it's simply not acceptable to wait for that kind of function of trickle down, if you will. So a hospital has to contract with a small community-based organization in order to no, we're and Christine can speak to this. How much more money do we have left? How many more settlements will we be able to draw from? I think we've peaked in terms of the most amount of settlement dollars that we're going to get. So what are we doing with the dwindling amount and recognizing the fact that reappropriations means that the money is there, the authority is there for it to be spent, but it's not out the door. So that's one of those things. Like Virginia, for example, their settlement board made a dedicated appropriation of settlement dollars to go to Richmond and 6 counties where the overdose rates in Black communities in those counties and Richmond had increased 200% from 2023 to 2025. They just locked it off and gave it, right? And I don't know if we can't do that, but that's what the Virginia Opioid Authority did. And that there's now a learning cohort or a cohort of this group who are figuring out what to do with that chunk of money. It's like $3 million, which is nothing, but it would be a lot if that money could be well directed. I feel like I'm on a soapbox yelling, so I'm sorry.
No,
I
no,
kind
you're
of,
doing everybody's great. Everybody's great. Thanks, Christine. Go ahead, Christine.
oh yeah, I just wanted to kind of like add to what Tracie's saying because I think that there's so many examples of what she's talking about. And another one that came to mind is we were happy to see that there was a project funded, several organizations received money to do low threshold buprenorphine, except almost all of the organizations funded to do that were like very large kind of traditional treatment providers that already have like an MOUD like project, they're already like prescribing MOUD, they're probably getting Medicaid reimbursement to do that. And like, I think the intention behind the low threshold buprenorphine is like small community-based organizations, harm reduction service providers that have like one doctor coming a week or every week, some communities where there aren't a
Christine,
lot
your
of
Wi-Fi
providers,
keeps
and that's not where to be able.
your Wi-Fi did it again.
Yeah.
Oh, no,
You're okay. You're okay.
really?
It's probably a good time, and I don't, because I'm not in the room. I don't know if there's anyone that has any questions in the room. If not, we can do some like closing sort of remarks. I can tell we're getting close to time because my dog's bugging me for his 3 o'clock treat. So, if there are folks that do have questions in the room, this is a good time to ask them. Again, wonderful group of folks in this panel, and just want to say like deep, deep knowledge of the New York of it all. They'll know more than anyone will ever know about the New York opioid settlement spending. So, oh, I see someone getting
Yeah,
up to the podium. There could be a question. We'll see.
I need a 3 o'clock treat too.
No problem here. It's just we have to unmute from our little system here. But I mean, this has been incredibly informative, and I hope that I'm able to share your information with our students so that they can maybe tap you as sources in the future as they start some reporting on this.
Awesome. Thanks, Casey. Yeah. So if we just want to have everybody kind of go around and maybe some final remarks on what you're seeing, what you're thinking, what is the big takeaway that you want a group of journalists to know about opioid settlement spending in New York? I know it's a hard question, and as everybody has said, and rightfully so, this is like a multi-day event that I just jammed into an hour. So thank you for being so generous with your time to talk about this topic. But Mishka, do you want to go first, and then we'll kind of work around?
I mean, there's so many things that we haven't touched on and that we've like only like briefly sort of touched on, but I feel like to pick one, um, um, it's like with drugs in general, we can't, every time there's like a new substance, everyone pretends that they don't understand anything about drugs or addiction or trauma or treatment or healthcare or wellness. And in some ways, our responses are sort of similar, and there's this ahistoricalness to all of this, and what Tracie and Christine have been talking about have been identifying parts of history that are I think really helpful and insightful. There's what Oklahoma did with the tobacco funds, which has put them into a research trust, which was not at all replicated by any state or anywhere with the opioid settlement. So it's just kind of like a footnote of what could have been. But also, I just really wanted to sort of key into Tracie when you were talking about like sort of the location of the funding within the mental hygiene authority as opposed to public health, and that illustrates this sort of the incomplete project of really of integration. And also like and really like and when you were highlighting the history of HIV AIDS, both in terms of public health and response, but more importantly in terms of community-based mutual aid activism, where I think a lot of people come from that, and that was a lot of learning in that. And this idea is, I think that if I want to say just like around harm reduction, and we think of it sort of as an end user like tertiary prevention kind of thing, but it's also like in epidemiologic terms like primary prevention, and really like probably like the one like the slogan, I guess a slogan from the HIV/AIDS era that I think really applies to this period of time, which is that like treatment is prevention.
Thanks so much, Mishka. Christine, do you want to go? I know you started us, so we'll have you go, and then Tracie, you can round us out.
Okay, hopefully my internet works, so I'll keep it pretty brief. But yeah, I think that yeah, obviously there's so much to say, and I'm happy if anyone follows up with me at any time. I think that the point, the kind of final point I want to make, kind of this department of the hygiene system we often say like treat this as a public health issue, but like the mental hygiene system is not designed for public health. And I think that's where a lot of it stems from. And then I think the second piece that Tracie makes this point, and I really learned a lot from Tracie, is sort of like from the inception, this was not designed by communities or really even experts. Like the approved uses came in the Attorney General settlement agreements by lawyers without a ton of experience or understanding of what they were frankly talking about. And now we've sort of had to like build upon what they did in those settlement agreements. And I think, from the start, that is just like not the right people. Yes, and it reads like that. And so it's just like started off wrong, and we're trying to like build and glom on to something that never was really right in the first place. And I think that there's just like a lot to dig into to kind of turn the tides. We have like, not that long left, frankly, like 14 years left. So I think it's urgent because that's going to go by like that. So thank
Yeah,
you for
Tracie, that's
having
what
me
I was going to
also.
say. Oh, of course, Christine. We're 4 years in, 14 years left, and people are still dying at really, really high rates. So I know that's not a great place to leave us. So you can lift us up with a better place to leave us, Tracie.
I cannot. I cannot. I could not possibly be on this as, a founding ED of the National Black Harm Reduction Network, which is about understanding that the response to the opioid overdose epidemic, and as Mishka said, this is not our first opioid epidemic. We have pathways that were formed by the previous opioid epidemic, which was heroin, and then kind of solidified by our response to crack. And so if we don't own the anti-Blackness that's built into these systems and keep calling it broken when in fact, as was mentioned, they're doing exactly as they were designed to do, which is to surveil, institutionalize, and basically oppress and repress groups of people. Black people and Native Americans, Native Indigenous folks have been the target of government public policies of destruction and undermining. And that is the canary in the coal mine. So the rest of the country got sick over what was killing us anyway. And so that is what for me, the urgency is of this settlement dollars. It should not have been structured like tobacco settlement funds. I did not know about the Oklahoma model, but we have a chance to reorient a system that never bothered to ask why people use drugs. We have a chance to have a system that doesn't make people sicker by coming in to care for it. And hence, informing a revolving door that, quite frankly, is in a moral, profit-driven, or it just continues itself by getting people just well enough to have to come back. And so that's my closing statement is we have an amazing opportunity. We cannot let government, I'm trying to say nice words. We cannot let the slow pace of government and bureaucracy get in the way of what possibilities we could do. HIV is not gone, but as a health emergency, we were able to tackle it. I did not think I would be alive to see you be able to prevent HIV transmission from an injectable long-acting drug. I did not think I'd be alive to see that. So I really believe that if we have a plan and a goal and a strategy, we can do that with overdoses. We can do that with substance use disorder and with the people who know best what is needed.
I actually think that was uplifting at the end because like this money can unlock that. But we have to work towards that, and journalists are going to be a big part of that, and being able to expose how the money is being spent, those process questions we were talking about, how it's not being spent, and just the missed opportunity that we've had for the last 4 years to make sure it doesn't continue for the next 14. So
Absolutely.
I took that as very positive, but I definitely hear the other parts of that, Tracie, as well. So Christine, Mishka, Tracie, again, just so wonderful to have the three of you here today. Shifting gears like last minute to do this remote was wonderful. Y'all have such deep knowledge on this topic, and New York is lucky to have people like you that are fighting for this money to be spent well. As much as we've talked about some of the problems, there are good things that are happening too.
Absolutely.
And there are good stories out there about those good things that are happening. The problem is there's also like just so much bad shit.